The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanik, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome to TMD Demystified. Today's installment we have entitled Making the Correct Diagnosis. So welcome to all those who are interested in solving the problem of TMD for your patients in your practice. We have solved the problem here in Middle Tennessee, and we are now helping other doctors throughout the United States solve the problem in their communities and for their patients. This is a big topic we'll talk about today. I'd like to try to make it brief. I know all of you who do view these podcasts have plenty to do, and I do appreciate your time and value your time as much as I value mine. Making the correct diagnosis for TMD is actually very simple. For some of you who have never treated TMD, or maybe some of you who constantly treat TMD, you would take issue with that. I understand. But as I went through the last 10 years with what I've learned about this problem, the actual usefulness of what I learned became more simple, more direct, more simple as time went on. So without any other kind of introduction, let me just simply say that if you know the symptoms associated with TMD, and you know a simple mechanism how to determine if there's inflammation within the temporomandibular joint, we've talked about inflammation extensively on prior installments of the podcast, you can nail down the diagnosis instantly. Now, let me make a comment and a disclaimer. I never have and never will say that all symptoms associated with the head and neck and shoulders and et cetera are coming from the temporomandibular joint. But I do know, and we'll cover this in just a few minutes, that there is extensive, significant, constant misdiagnosis of temporomandibular joint problems coming from the joint that are misdiagnosed as other things and treated as other things, and some of it is significantly damaging and dangerous. So how do you diagnose TMD? It's quite simple. If you know the symptoms, first of all, and I'll just briefly run through what's covered on our course, teaching other doctors how to do this, is I have a kind of a 3-4 step procedure. First step is introduce myself, sit down and listen. Listen to what the patient has to say about this, but you don't have to sit down and listen for 30 minutes. Basically guide the patient to tell you what their symptoms are, not what some other doctor said about this, not what they read on the internet, what Aunt Molly said about it, but what is bothering you? What are your symptoms that drove you here that you want fixed? And you sit down and listen to those, and you will learn a whole lot. This is important. This is not just something to keep the patient comfortable and build confidence. It's very important because you will learn tremendous amounts from the patient's point of view about these symptoms. But to review very quickly the symptoms, and then there are others. I'm learning that there are other symptoms, and we're going to do some studies and some things later on to confirm that. But the well-known, accepted symptoms of TMD include, in order of frequency, the way I have them listed, frequent or recurring, specified that way, frequent or recurring, headache, earache, jaw pain, neck pain, ringing in the ears, tinnitus, feeling of fullness in the ears, like you've been swimming and can't clear your ears. That's what patients relate to quite frequently. Vertigo, dizziness, shoulder pain, upper shoulder pain, arm, hand, finger tingling and numbness, and of course, locking of the jaw, closed lock. Those are the symptoms. And so you sit down and listen to what the patient needs and wants. What's their problem? What are their symptoms they want solved? And then I go through a very brief description of the symptoms, and I ask them to check off. I go list those symptoms. Do you have or have you ever had those symptoms? And then mentally, I check off the ones that they have so that I can get it in the notes properly. And then I describe to them why inflammation in the joint causes all those symptoms. And later on in these podcasts, we're going to do some videos of actual patient consultations that I did. And we run through this very briefly. It usually takes me 15 to 20 minutes to do a total, complete consultation regarding TMD. The second part is then, once you've established what symptoms they have, you're suspicious. You haven't made the diagnosis yet. You are just suspicious. They might have 2. Most of them have 5 or 6. Many of them have 10 or 12. Now you're suspicious or really suspicious. When you do enough of it in your mind, you know, yeah, this person's got TMD, but you can't make your diagnosis until you do your exam. The exam is very quick and very simple. I want to know how far they can get their mouth open. This tells you whether they have any locking, closed lock, inability to open fully. Note that. I always put a finger on the top of the coronoid process, insertion of the temporalis muscle. 99% of the time, if they have TMD, they're going to go, ouch. And again, that didn't make the diagnosis yet. You're just suspicious. What you know when that occurs, when you put your finger intraorally, both sides, and reach the top of the coronoid process in the full open position, have them open widely, and touch the coronoid, and they go, ouch, it hurts, or they pull back. You know that the temporalis muscle is tight. It's pulling on the coronoid. And of course, that's where the pain is. We covered that before. Pain comes from the nocioceptors on the periosteum. Now you're really suspicious, but you haven't made your diagnosis yet. The final thing, and I've mentioned this before in previous podcasts, is that you find out whether there's inflammation in the joint. How do you do that? Well, it's not going to be seen on X-ray. There's no blood test. There's nothing, complicated to it. You stand behind or beside the patient and instruct them. First, show them how much pressure feels like. Well, this is a lot of pressure. Make sure they understand what pressure feels like. Then tell them what you're going to do is have them open widely. You're going to put pressure on the joints and then have them close quickly. What I say is don't open nor close till I tell you to, but when you close really quickly on your back teeth like you normally do. When they open widely, let your fingers protrude or insert into the glenoid fossa. As the condyle comes out of the glenoid fossa, you can feel it, unless the patient is too beefy here. Sometimes it is kind of hard if they're beefy. But push hard into the glenoid fossa and then say, bite on your back teeth quickly. Have them bite, not chew, just bite, close once. And if the joint is inflamed, they will say, ouch, it hurts, or pull back. The next question is, how do you grade that pain? Right and left side, 1 to 10, 10 being the worst. And they'll give you a subjective number. It's important, put that number basically, but you have made that, put that number in your chart and you'll have an idea which joint hurts more, but that's kind of irrelevant. It's just that it hurts. A normal joint, when you do that, that isn't inflamed, doesn't hurt, doesn't give you a symptom. When it hurts, you know the joint's inflamed. That's all you know. It's irrelevant where the disc is. It doesn't make any difference. It doesn't make any difference what the x-ray looks like. It can be a terrible looking x-ray with a lot of damage or a total normal looking x-ray. But what you do know is the joint's inflamed. The definition of temporomandibular joint disease, TMD, as we call it in my office, not TMJ, but jaw joint problems, JJP, and patients even bring that out now. That I make that distinction early on. We around here, we call it jaw joint problems, not TMJ. Anyway, I have a little scenario I'll go through with that. But the point is, you've made the diagnosis. That's the key. You've made the diagnosis. Anybody can do that. You don't have to be a professional to do that. You don't have to be a doctor. You can be public. And we actually have a little video that shows that. and we produced, and is now on the internet and social media, and encouraging and instructing patients how to self-diagnose, because the second part of what I have to say is actually most important: the misdiagnosis of this problem. Anyone who has treated TMD to any extent, I know, has run into patients who have been misdiagnosed with something else by a doctor, or some of them self-diagnosed, but by doctors who have been diagnosed with something else that actually turns out to be TMD. Definition: inflammation in the jaw joint, in the temporomandibular joint. So I put together a very brief list of, it's not extensive, but it's the most common, the ones I see pretty frequently, some of them constantly, of patients who come in who have been given misdiagnosis and treated for these problems extensively, sometimes by multiple doctors, sometimes by multiple treatments, sometimes by irreversible treatments, sometimes by damaging treatments. Hopefully that doesn't happen too much, but in my practice, I see it significantly, and sometimes super significantly. So first, let me just run through the list of misdiagnosis, and this is not made to be critical of other doctors. As both a dentist and physician walking both rails, I understand my colleagues. I think you can see with my white hair, I've been doing this a while, and I have empathy. I have empathy for my dental and physician colleagues because of all of the difficulties we have in our careers and in our profession, and our conflict with insurance companies, and trying to do a good job at what we do. And we're pretty much focused on a specific area and kind of routine of our job. And unless you have the right information and the right education and really see what TMD is all about, you don't think of it. And then patients come in with these symptoms that actually have come from, or you think you've come from, other diagnosis. You make your diagnosis and you treat them as such. So here's the list, and we'll go through these. I'll just give the list first, and then we'll go through them one at a time. I'll have some comments for each one. Common misdiagnoses are migraine headaches, fibromyalgia, Meniere's disease, dental abscess. I have a lot to say about that. I have a lot to say about all of these. Impacted third molars. I have a lot to say about that. Sinusitis, common. Trigeminal neuralgia, that's a catch-all. When the other doctors don't know what to call it, they just call it trigeminal neuralgia. Unusual facial pain. Neck and disc dislocation. Carpal tunnel syndrome. And something that most of you are familiar with is called Chiari malformation, which is a specific neurological disorder where the brainstem and the cerebellum comes down through the foramen magnum, and that can be very damaging. So let's take these one at a time very briefly, and give you a little intuition on like what I see constantly. So migraine headaches, people are diagnosed or self-diagnosed all the time, and they come in and actually 80-90% of the people say, I have migraines. It's because of television and internet. Everybody's indoctrinated. If you have a bad headache, bad headache, you call it a migraine. Well, migraines have been very well studied. Tons of papers on migraines. First thing you know about migraine headaches when you read the papers is not one of them indicates that they know what causes migraine. The first thing they say is, we do not understand what causes migraine. We have a lot of information about migraine headaches. We think it's this, we think it's that, but we don't know really what causes migraines. Well, I know that a lot of people, tremendous number of people, come in with the moniker, with the diagnosis of migraine, and you make the inflammation in the temporomandibular joint go away, and their migraines go away. If Fibromyalgia, that's another female disease primarily associated with the estrogen cycle. That's why fibromyalgia is primarily female. As the estrogen cycles, the inflammation cycles and gets worse. And that's why fibromyalgia, which is an inflammation disease throughout the body, and it's not just upper body or neck, but frequently people come in and my doctor said this must be fibromyalgia. Well, no, it is inflammation in the joint, which causes neck pain, upper shoulder pain, arm, hand, finger tingling and numbness, stuff like that. Meniere's disease, my ENT colleagues know that they don't have a answer to Meniere's disease, but they frequently come in with the diagnosis of Meniere's, and when the inflammation in the joint goes away, their diagnosis goes away, Meniere's goes away. Dental abscess. This is one that I didn't actually believe. I mean, I found it hard to believe that temporomandibular joint inflammation will cause the symptom that it feels to the patient like their teeth hurts, but it does. I have seen more than I want to see. How many? I mean, in a span of 7 years, I've probably seen 20 cases, 25 cases of patients who have actually talked the dentist into taking out perfectly natural, healthy teeth. They say, my teeth hurt. The dentist says, and it's the same story. The dentist said my teeth was okay, but it hurt. So, I went to another dentist and he took out the tooth or teeth. And they come in my office with same symptoms and they have a few teeth missing in both the upper and the lower. It can occur mostly in the maxilla, but I've seen it also occur in the mandible, which is a shame. It's just a shame. So a patient comes into your office and they say, my tooth hurts, and you do your periapicals and you do your exam and you examine it carefully and say, I don't see anything wrong with this tooth or these teeth. Ask if they have other symptoms, go through the list and do this. More likely than not, you're going to come up with a patient with TMD. Impacted third molars. To my oral or maxillofacial surgery colleagues, I have a message. I've been doing this, again, quite some time. In my earlier career, I am certain that I have missed patients who came in to see me because they were having pain that they thought was coming from their impacted third molars, and that I took a look at them. I took a look at the x-ray. I took a look at them. My thought process was, that if they're impacted, you got impacted third molars, and there are really good reasons to take out impacted third molars, but these impacted third molars are not causing pain. They're either too deep or there's no inflammation. There's no reason for these teeth to be causing pain. But I said, well, yeah, I'll be happy to take your wisdom teeth out. And we put them to sleep and took their wisdom teeth out. And that did not fix their pain. So for my oral and maxillofacial surgery colleagues, when someone comes in and they want their wisdom teeth out, you ought to ask them, are you having any pain? Oh yeah, this is just really hurting. Which side? Where? Oh, it's up here, it's down there, whatever. Take a look at the tooth, and if it is not symptomatic, you don't see any inflammation, it's unlikely that tooth is causing any pain. In fact, it's impossible. If it's not inflamed, it's not causing pain, because inflammation is one of the primary characteristics of pain is one of the primary characteristics of inflammation. So do this little number, and if they go, ouch, you have qualified, you have made your diagnosis, and you won't misdiagnose the patient. Take their wisdom teeth out because they need them out, but make sure they understand that taking their wisdom teeth out is not going to help their temporomandibular, their pain, but you can treat their TMD non-surgically. Sinusitis. Just this week, I saw 2 patients this week who came in. They've had multiple episodes. One patient had seen several ENT doctors, and the other one, and I don't exaggerate, she said she had had 4 separate sinus surgeries because of her constant and chronic sinus pain. The got a Panorex. The sinuses were clear. I didn't see anything wrong with the sinuses. She already had 4 separate surgeries. She was sitting in my office with the same pain. I took the symptoms down. She had multiple other symptoms involved. I pressed on the temporomandibular joint, did the self-examination, and exquisitely painful, exquisitely painful. And so we have her under treatment, and she took impressions, and I am certain that within a few weeks after we start treatment, her sinusitis pain will go away. Very common symptom that patients confuse, doctors confuse. I mean, if they come in, if the patient says, "Doc, it hurts here or here," they'll either be treated for or sent to a doctor who treats sinusitis. I think I mentioned trigeminal neuralgia is the catch-all phrase. Trigeminal neuralgia, when you read up on it, is a very specific diagnosis, very unusual. The thing that specifies trigeminal neuralgia as opposed to any other diagnosis is a trigger point. That we know. Do we have it fully explained? No, we don't. We don't understand trigger points. We do know that sensation directed back into the central nervous system, and then it gets all mixed up, but then that can trigger a significant amount of pain. But, most physicians who get an unusual facial pain or unusual history from a patient, they'll call it trigeminal neuralgia. And trigeminal neuralgia is frequently treated by some pretty specific and powerful drugs that have powerful side effects. So if you suspect trigeminal neuralgia, or someone comes in with trigeminal neuralgia and say, "I have a history of trigeminal neuralgia," you might want to consider taking their history and those 12 items, asking them if they have any of those other affiliated symptoms, and doing that. If they have inflammation in the joint, you've nailed down your diagnosis. Disc and neck dislocations. Obviously, you can have disc problems, and I have seen many that are valid, disc dislocations that need neck surgery. On the other hand, I have seen several patients who have had neck surgery that actually was their neck pain originated from the temporomandibular joint. I've seen it, and so it's easy to distinguish. And we're out there constantly educating our ENT colleagues here in Middle Tennessee as how to do this if the patient has some neck pain that is unusual, or they think, "I don't see anything really significantly wrong with your neck." Carpal tunnel, had several patients already who have had carpal tunnel surgery because arm, hand, finger tingling and numbness is a known, easily understood symptom coming from temporomandibular joint inflammation. When the neck muscles are giving the direction to tighten up, and it tightens up the brachial plexus, it causes arm, hand, finger tingling and numbness. Patient goes to their PCP and says, I have hand or finger tingling or numbness. First thought is you have carpal tunnel, and they sent it to an orthopedic surgeon who does carpal tunnel. And, if he doesn't think, well, maybe it could be something else, off they go and they do surgery, and they come back 6 months or a year later, they're still having symptoms. You do that little number and it hurts, and make the inflammation go away, and their arm, hand, finger tingling numbness goes away. The last one is Chiari malformation I want to talk about. That is pretty serious because I have seen now 2 patients here in Middle Tennessee who have had neurosurgery to enlarge the foramen magnum, which is the surgical procedure to affect relief of the severe headaches that can be documented, can be seen when the brainstem and the cerebellum perforates through the foramen magnum. But they didn't have Chiari, they didn't have the Chiari symptom complex. What they had was TMD. and they're sitting in my office a year later, 2 years later with the same symptoms. Their joints are inflamed. You make the inflammation go away non-surgically, and their headaches go away. Headaches are actually the primary reason that you do that surgery, severe untreatable headaches. And I've seen 2 cases that have been misdiagnosed. So that's food for thought for everybody. My last comment about this, and I'd like to wrap it up, is not every pain associated in the head and neck oral area is associated with TMD. So you can yourself misdiagnose this. You have to be careful. I have personally witnessed my own patients 2 cases of occult cancers that masqueraded to me originally as temporomandibular joint problems. One was, both of them were pharyngeal cancers. One patient couldn't open his mouth but 20 millimeters. And they were occult. They weren't obvious in the mouth. They were deep down in the pharynx. So you have to be cautious. I say that sincerely. Not everybody that comes in your office with head and neck, shoulder pain is going to have TMD. But it's reversible. And, if you have an occult cancer and you can't make it is, misunderstood, and you misdiagnose it as TMD, the important part is that you always follow your patients. If you are treating a patient non-surgically with our oral device that unloads the joint long enough to make the inflammation go away, and you don't get the response, and you know what the typical response is, within 3 to 4 weeks or less, they're going to have significant relief of their pain if you follow the protocol. There are a few variations which we teach in the course, but still it's very easy to make the determination whether your device is successful. And we know what the statistic is: extremely successful. Our study's coming out pretty quickly now. So if you happen to misdiagnose it, and we've all misdiagnosed things, I've misdiagnosed things, I don't claim to be perfect, you can recover very rapidly. It's like, what, this doesn't seem like a typical TMD. If you're a dentist, let me send you to your physician, call up the PCP and say, what, I thought this might have been TMD. Or you might call the ENT colleague and say, I really thought this was TMD for these reasons. The joint was hot, or I thought the joint was hot, and he had other symptoms involved, couldn't open his mouth, had headaches, jaw pain, neck pain. But I'm mystified now. I really need to check and make sure it's not something else. And the PCP or the ENT will order a CT scan or an MRI and look around. And that's how we found one patient. I found it. I actually got suspicious myself and ordered an MRI. Sure enough, it came back, and I went, oh my God, so I sent the patient off for definitive surgical treatment. So don't be so high horse that you think that you know it all and you can't make an error. Be cautious because you can miss a diagnosis, but it is very infrequent. I mean, those 2 episodes I had were based on over 5,000. Well over 5,000 consultations. So that's what I have to say today. I appreciate your attention as always, and I encourage your questions. I'd love some questions. I'd love some comments, and definitely love some questions. You can send your questions into our office at Naomi, Naomi, Naomi at tmjservices.net. If anyone would like to learn more about how to use our protocol and device and join our network of doctors throughout the United States and Canada who are using our protocol and device to get the same results that we have in solving the problem of TMD, you can contact Naomi. You can go to our website, www.tmjservices.net, and learn more. You have to take a course. We have an online course, and once you take the course, you're licensed to do it in your community for your patients. And I'd love to see you get involved, because I can't treat all these patients myself. And my colleague here that I hired into our practice here, both of us together can't treat all these patients. We can hardly keep up with the patients here in Middle Tennessee, and that's a fact. So have a good rest of your day. Have a rest of your week. I hope this is very successful for your practice. And anyone who'd like to communicate with us, please do. Thank you, and I'd look forward to speaking with you at our next installment of TMD Demystified.